So, after having discussed regarding the clinical presentations of glomerular disorders, we are moving ahead to discuss regarding the individual glomerular disorders, okay, because I have already told you, okay, there are lots of glomerular disorders which have varied presentations. So, let's try to discuss these disorders. And what is the first disorder that we are going to discuss? We are going to discuss regarding minimal change disease. Minimal change disease, which is abbreviated as MCD, minimal change disease. So first of all, let's try to understand what is this minimal change disease. See, the minimal change disease, okay, this is actually grouped under a glomerular disorder. But remember that this is actually a podocytopathy. This is a podocytopathy. And what do I mean by a podocytopathy? Some disorder in which the podocytes, that is your visceral epithelial cells of the Bowman's capsule, are affected. So it is a podocytopathy. And what is the exact change that happens in the podocytes in case of a minimal change disease? There occurs effacement of the food processes, okay, there occurs effacement of food processes of podocytes, effacement of food processes of podocytes. That is what happens in case of your minimal change disease. So which means normally you have the interdigitating food processes of the podocytes, okay, which are closely adherent to your glomerular basement membrane, okay, and it forms a very important component of your filtration barrier. So what happens is that here there occurs a flattening of these food processes, okay, plus there can sometimes be a fusion between adjacent food processes. And do not think that just because there is some fusion, the barrier is going to be more strong. No. Once there is a podocytopathy and once the normal podocyte structure, okay, is changed to a flattened structure with adjacent fusion, in fact they become more leaky, okay, which is why when I discuss regarding the clinical presentations, I specifically told you one thing, that whenever you have a podocyte affection, you will have a nephrotic range proteinuria, or in fact we can say like this, among the components of the filtration barrier, that is your capillary endothelium, glomerular basement membrane and the food processes of the podocytes, it is the podocytes which are most important for preventing a protein leak into the urine, the most important one. Yes, the other layers are important, but this is the most important one, and there occurs a food process effacement, okay, a food process effacement occurs, so there is some sort of a flattening happening and there is some sort of a fusion happening, okay, so that is what happens. And do you want to have a look at a simplified diagram, okay, of this, okay, yeah, so on one side we have a normal glomerulus, okay, and on the other side is a glomerulus with a minimal change disease. You can see in both conditions the capillary, this yellow, that is the capillary endothelium, okay, the capillary lumen, as well as the basement membrane, the glomerular basement membrane is intact, but the change actually happens to the podocytes, okay, and what change happens? You can see it slightly becomes flattened and then there is some sort of a adjacent fusion happening. Are you able to see? I'll just highlight it here. You know, you see this podocyte, you see this, you know, it is very much flattened out, okay, plus you might have fusion between adjacent podocytes, okay, and you may also notice, are you seeing some villi like projections, okay, a villi like projections from the podocytes, okay, so that is also a feature of minimal change disease. So rest everything is normal. The red one is a mesangium, perfectly fine. So this is what happens in case of a minimal change disease. Remember, if somebody asks you what is a minimal change disease, it is a podocytopathy. Okay, all right. So having understood what is the disorder, let's try to see, how does it clinically present. Okay, see, first of all, coming to the age group. Okay, coming to the age group, the classical age group of affection of your minimal change disease. Okay, the classical age group affection is 2 to 6 years. Okay, 2 to 6 years, maybe 2 to 8 years. So that is the approximate age group of presentation of your minimal change disease. And this is slightly more common in males, okay, than females. Slightly more common in males than females. Okay, all right. So please understand that the clinical presentation, okay, when you are going to the clinical presentation, I will tell one line to begin with. The clinical presentation is with what? It is with nephrotic syndrome. Because you remember, I have already discussed nephrotic syndrome in detail in the previous module. So I will just say that the presentation is nephrotic syndrome. Okay, that is very, very important. And when I say nephrotic syndrome, minimal change disease, please understand that the MCD, minimal change disease, almost 70 to 90% of nephrotic syndrome in children, okay, in children is because of your minimal change disease. Okay, see this number, 70 to 90%, which means this is the most common cause of nephrotic syndrome in case of children. What is the most common cause? Minimal change disease. Very clear. And also this would account for about 10 to 15% of cases of nephrotic syndrome in adults. So if you ask me, can it occur in adults? It can occur, but remember, mostly it is seen in case of children, 2 to 6 years. That is the age group of presentation. Okay, so it is mostly a disease of children. And how does it present? It presents clinically with a nephrotic syndrome. So at that time itself, I am sure you would be thinking of the components of nephrotic syndrome, which I have already discussed. Tell me, now you must tell me what are the components of nephrotic syndrome. Tell me. There will be proteinuria, okay, yes, and there will be hypoalbuminemia, there will be edema, there will be hypercholesterolemia, as well as there will be lipiduria. Okay, lipiduria is there. And in addition to this, you can have certain complications also developing, okay, in certain patients. But in general, let me tell you, you will have a child, maybe 5 years, 6 years, presenting with what? Okay, the presenting symptom might be that of a generalized edema. Okay, will be that of a generalized edema, that is your anasarca. Generalized edema will be there. Okay, so all these puffy eyes, okay, moon facies, generalized edema, almost a bloated appearance. Okay, so generalized edema will be there. And you may also have ascites, correct? You may also have ascites, okay, because you have third space loss. Because of the hypoalbuminemia, the oncotic pressure is low. The difference between hydrostatic pressure and oncotic pressure is high. It goes to the third space. Okay, so you can have ascites. Okay, so that is how they will clinically present. Okay, with nephrotic syndrome. Okay, generalized edema, ascites. Okay, you have got to keep in mind that. And just one thing to tell you. See, I told you this can present in case of children and adults. In adults, the edema component may not be that prominent, okay, compared to the children. Okay, children are likely to be more edematous. Okay, so you have got to keep in mind that point also. Now, see, what if, what about these features like hypertension? Okay, I am writing a few features. You tell me, is it common or not in this disorder? Okay, hypertension, maybe hematuria. Okay, hypertension, hematuria, and raised serum creatinine. Raised serum creatinine. You tell me, is it common or uncommon in this disorder? Let me tell you, it is very uncommon. Okay, it is very uncommon. But let me remind you one other point also, that adult nephrotic syndrome may have these features. Adult minimal change disease may have these features, but whenever you have a patient, maybe a 5-year-old boy presenting with a nephrotic syndrome, if he is having a hypertension or maybe a creatinine is raised or maybe he has some microscopic hematuria, then you should always think, is it minimal change disease? Because see, when you see a patient, a child with nephrotic syndrome, since 70 to 90% is because of a minimal change disease, you can almost assume that this might be a minimal change disease. But when you have certain atypicalities, you should think, okay, is it minimal change disease? It can happen rarely, especially MCD in adults, okay, but relatively uncommon. Okay, you have got to keep in mind that point. And also remember, in the clinical course of patients with nephrotic syndrome, I already told you they are prone to certain complications. So patients with nephrotic syndrome are prone to certain complications, one of which is infections. Okay, infections, very important. So patients with nephrotic syndrome probably having ascites, they may develop a pneumococcal peritonitis. Okay, they may develop a pneumococcal peritonitis. They may develop a pneumococcal peritonitis. Okay, so that is again very, very important. Okay, so this is one reason why a patient with a nephrotic syndrome may develop an abdominal pain. So he can develop an infection and subsequent peritonitis, and often it is a pneumococcus that causes peritonitis in such individuals. Okay, infections. Similarly, increased chance of thrombosis. So either a cerebral venous thrombosis can be there, renal vein thrombosis. So such complications can happen. And another point that you have got to keep in mind is that patients with nephrotic syndrome, okay, they are likely to have, especially the children, they are likely to have rickets as well. Okay, so they are likely to have rickets because of the loss of substances in the urine, the minerals are lost. So there is a possibility of rickets also in such individuals. Okay, all right. Now, since in case of a minimal change disease and nephrotic syndrome, there is lots of third space loss. Will you agree with me that there is hypovolemia in these patients? Though they appear very much bloated, the intravascular component is actually less because all the fluid is going to the extravascular component. So sometimes they may go for a hypovolemic shock. Okay, hypovolemic shock. It is not common, but sometimes may happen in the setting where a patient with nephrotic syndrome is being over aggressively treated with diuretics. Okay, so somebody has not checked the blood pressure and is keeping on giving diuretics, he might go for a hypovolemic shock. Okay, so and again, remember about the thrombosis. We have already seen the reasons for thrombosis. Okay, and here again, when you give unnecessary diuretics, okay, there is further hemo concentration developing in the individual and there can be thrombosis. Okay, the other mechanisms of thrombosis we have already seen in case of the previous module, okay, where we have discussed nephrotic syndrome. Okay, so infections, thrombosis, rickets, hypovolemic shock, and yes, you can have growth retardation as well. Okay, growth retardation as well. Okay, so all these are the complications that may develop in case of nephrotic syndrome. Okay, all right. So another point that you have got to note is that, see, you may have secondary, this particular condition may be secondary to certain disorders. Okay, that is, you may have a secondary minimal change disease. Okay, so secondary minimal change disease means it is some other systemic disorder in which you can also have minimal change disease as a manifestation. So what are the conditions that can produce a secondary minimal change disease? See, it may be a part of malignancies. Okay, it may be a part of malignancies. That is, it may be a part of Hodgkin's lymphoma. Hodgkin's lymphoma. It may be a part of the mycosis fungoides, which is a cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma. And also you may get this in chronic lymphocytic leukemia. Chronic lymphocytic leukemia, which is your CLL. But at this point of time, let me remind you that usually in CLL, okay, we are more likely to get MPGN. What is MPGN? Membranoproliferative glomerulonephritis. Okay, membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis. So that is what commonly occurs in CLL, but you may also get a minimal change disease. So one is you can have association with malignancies, secondary minimal change disease. Maybe even in thymomas also you may get minimal change disease. Second is you may develop minimal change disease in association with certain drugs also. Okay, in association with certain drugs also. Any guesses on what drugs are likely to produce minimal change disease? One is going to be NSAIDs, non-steroidal anti-inflammatory drugs. You already know they are likely to cause pre-renal acute kidney injury. Okay, but keep in mind that and also we have learned regarding allergic interstitial nephritis also occurring in NSAIDs. And remember that secondary minimal change disease also can occur with your NSAIDs. Okay, so the NSAIDs can produce. Next is you can have interferon alpha. Interferon alpha, that can produce a minimal change disease. You can have lithium that produces minimal change disease. Okay, but here again remember one point. Usually, okay, lithium is producing a chronic interstitial nephritis. A tubulointerstitial nephritis is what lithium commonly produces, but it may also produce minimal change disease. Okay, so lithium and gold as well. Okay, lithium as well as gold. And gold also, one point you have got to remember, normally the gold actually produces a membranous nephropathy. Okay, usually it produces a membranous nephropathy. Okay, but can also produce minimal change disease. Okay, now after drugs, number 3, you can also have minimal change disease in association with allergies. Okay, in association with allergies. That is, in individuals who are having, say, atopic dermatitis, okay, or maybe allergies to house dust or pollen or insect bite. Okay, insect bite, or even sometimes rarely associated with immunization as well, vaccination. Okay, in association with immunization. Okay, also you may develop minimal change disease. Okay, so these are the causes of secondary minimal change disease. So it is very important that you have got to search for the secondary causes of minimal change disease, especially in adults. So whenever you have an adult with a minimal change disease, before concluding that this is a primary minimal change disease, a primary glomerular disorder, always try to rule out the secondary causes as well. This is very, very important. Okay, so far we have understood what is this disorder. We have understood how does it clinically present. Okay, and we have also understood the primary and secondary minimal change disease. So very clear. So a patient has presented to us. Okay, how are you going to evaluate? So evaluation for a child presenting, you have got to look for the urine protein. You have got to estimate, okay, how much is the urine protein excretion, okay. You have got to test the cholesterol levels, okay. So all workup that you routinely do for a nephrotic syndrome, and you have got to, like, if needed, you can go for a chest x-ray as well, because sometimes some individuals, because of the fluid going to the third space, may have some sort of a pleural effusion. Sometimes ultrasound abdomen may be required. You might be having an ascites, okay. So the basic workup you have got to do, okay, the basic blood investigations and the urine examination and a chest x-ray, okay. You have got to do all these investigations. And then let me ask you one question. The question is this: will you go for a biopsy? Will you go for a biopsy in patients with a nephrotic syndrome, a child with nephrotic syndrome? See, in case of a child with nephrotic syndrome, suppose if I am having a 6-year-old boy with nephrotic syndrome, see, I am almost 90% convinced that this is a minimal change disease. So in such a condition, I would not go for biopsy straight away. I will treat the patient, and if the patient is not responding to my treatment, then I might consider a biopsy. But generally, in case of children in whom the chances of a minimal change disease is very high, you will not go for a biopsy. But take my words, any adult with a nephrotic syndrome, you have got to go for biopsy. Okay, you have got to go for biopsy in any adult with nephrotic syndrome. Okay, so adult nephrotic syndrome, no doubt, adult nephrotic syndrome, any day you have to go for a biopsy. Okay, you have got to go for a biopsy. And what about a child? Will you go for a biopsy in a patient with a nephrotic syndrome? Will you go for a biopsy in any circumstances? There are certain circumstances that you will go for a biopsy. That is, biopsy you can go for, okay, in case of children. One is if the age group is less than 1 year. Because see, if it is the classical age group is 2 to 6 years or 2 to 8 years, you can call it. So if there is a less than 1 year of age group, then you should actually go for a biopsy. And suppose, if there is, you have treated the patient and the patient appears, steroid resistant. Okay, he appears steroid resistant, not responding to your treatment. In that case also, you have got to see, is this actually minimal change disease? Is it some other disorder like a FSGS, focal segmental glomerulosclerosis? So you have got to go for a biopsy. Okay, and you have got to go for a biopsy in certain other scenarios. Like suppose you have got a patient with a nephrotic syndrome, okay, a child with a nephrotic syndrome, and he is having low values of complement. Okay, so normally it is a glomerulonephritis where you expect low complement levels. But if the values of complement is actually very less, okay, in that case again you will go for a biopsy. Okay, so these are some of the indications where you will go for a biopsy in children, but in general you will first treat the children. Adult, anyway, biopsy needed. Okay, very clear. Now suppose you have gone for a biopsy. Okay, so what are you going to see in the biopsy if it is actually a minimal change disease? Okay, I am talking of a minimal change disease. See, if it is a minimal change disease, let me begin by telling you that when you do a biopsy, the light microscopy as well as your immunofluorescence, in case of your minimal change disease will be normal. Okay, will be normal. Okay, so all these changes that we discussed, the effacement of food processes, all these will become obvious only in what? Electron microscopy. So you have got to go for an electron microscopy to see the effacement of food processes. Okay, so that is very essential to see if it is a minimal change disease. But remember one point, okay, I'll just show you a biopsy picture. So this is the light microscopy, okay, light microscopy. See, you can see here, this is actually a light microscopy picture of a patient with a minimal change disease. See, the capillaries, everything is actually appearing very much normal, and also you are not seeing much of any mesangial deposits. You are not having any other capillary changes. Everything is looking normal. So that is how you will see the light microscopy in case of a minimal change disease. But some cases of minimal change disease, some cases may show IgM mesangial deposits. So IgM mesangial deposits in some cases. Okay, in some cases you may get IgM mesangial deposits. Okay, very important. So remember, it's not a common finding, but some cases you may get IgM mesangial deposits. If you observe IgM mesangial deposits in a possible minimal change disease, it's not a good sign, because the patient can actually go for a chronic kidney disease. Okay, so you're not expecting IgM mesangial deposits generally, but if present, not a good sign. Okay, all right. So then you see here, this is the light microscopy, and subsequently you can see the electron microscopy, because I told you light microscopy is generally normal. So Cl is your capillary lumen, okay, P is your podocyte. Okay, so what happens is, if you closely observe the arrows here, just look at these arrows pointing. See, what you can see is that the podocytes and all, there is actually fusion of the food processes. So it all appears as a single layer. Okay, it all appears, the podocytes, it appears like a single layer. Okay, fusion occurs. Not in all places probably, but in many places there occurs fusion. Normal interdigitating food processes, which I have shown you the picture, I am sure you have that in your mind. So that is not there, there is effacement. So that is what happens in the electron microscopy in case of your minimal change disease. Okay, so that is very, very important. So that's it on the biopsy findings in case of a patient with a nephrotic syndrome with suspected minimal change disease. Okay, we have seen that. So after having discussed this, let us now move on to what? We are moving on to the treatment of minimal change disease. Okay, so let's move to the treatment of minimal change disease. Minimal change disease. So first of all, remember, this is more of a pediatric topic, because the minimal change disease is more commonly seen in case of children. Okay, so let me just start with telling you this, that the treatment, okay, whether it be a minimal change disease in children or adults, you are going to start treatment with steroids. Okay, so you are going to start treatment with oral prednisolone. Okay, you are going to start treatment with oral prednisolone. So in case of children, okay, in case of children, you will go for 2 mg per kg per day in case of children. Okay, whereas in case of adults, you will go for 1 mg per kg per day in adults. Okay, oral steroids, children, adults. Okay, so one thing is clear, you have decided to start treatment with steroids. Next question, how long? How long will you treat? See, you will treat in such a way that you are going to go for a 6+6 regime. Okay, 6+6 regimen, by which I mean, see, for the first 6 weeks, you will give the full dose. Okay, you will give the full dose, that is 2 mg per kg in case of children and 1 mg per kg in case of adults. And the next 6 weeks, what you will do is that you will go for tapering. Okay, if it is children, what you will do is that instead of the 2 mg per kg, you will make it 1.5 mg per kg. Whereas in case of adults, you can subsequently taper the dose down. Okay, like suppose if the patient was started on 60 milligram, you can bring it down into 50, 40, 30, 20, 10, like that over one week. So totally you will give it for a period of 12 weeks. Okay, so that is how you will treat a case of a minimal change disease. Okay, so in case of minimal change disease, especially in children, they have good remission, which means the MCD is one disorder, okay, that is having a good treatment response. Okay, it is having a good treatment response because see, all you have is some effacement of food processes, nothing much. Okay, so just one point also to add at this moment, I told you not much of lesions. The minimal change disease is also known by the term, okay, MCD is also known by the term nil lesion. Okay, because per se you are not having much lesion, so it is a condition of nil lesion. And also another name for this condition is lipoid nephrosis. Okay, so just in case somebody asks you what is a lipoid nephrosis, it's nothing but another term for your minimal change disease. Okay, very clear. So I told you the minimal change disease will be having good remission. Okay, all right. Now what is this remission? Okay, when I say remission, what do I mean? See, a remission means when you test the urine, because whenever you have a patient who is admitted, for a nephrotic syndrome, you have got to see if the patient is in remission or not. So for that, you have got to measure the protein in the urine samples. So when the urine sample, okay, when there is no albumin, okay, so when there is no protein, okay, no protein in 3 consecutive samples, in 3 consecutive urine samples, which means either, the urine is actually showing 0 or maybe sometimes trace. 1+ you cannot take it for remission, but a 0 or maybe some trace you can take it as a remission. That is, if it is 3 samples are showing absence of this proteinuria. Okay, so that is when you say that the patient is in remission. Okay, so you are treating this patient 6+6 regimen steroids. Okay, but remember that the steroid management is important to make the patient in remission. But in addition to steroid, remember that nephrotic syndrome is a condition that is not just managed with steroids. You have got to take into account other factors also. Like, see, this is a condition where your albumin is less and you are having third space loss. So what about the management part dealing with the fluid as well as the electrolytes? So first of all, you have got to, along with the steroids, okay, certain other aspects in the management are, one is you have got to go for fluid restriction. Okay, fluid restriction, which means how much will you restrict? That is, your restriction should be in such a way that your intake should be equal to the previous day's urine output plus insensible losses. Okay, so that will be the fluid restriction. And what about salt intake? Again, it is a salt restriction. Okay, it is a salt restriction. And what do I mean by salt restriction? It means that there is no added salt in the diet. Okay, no added salt in diet. You are not putting any salt into your curries. Okay, so no added salts. So fluid restriction, salt restriction. And what about proteins? See, protein, already you are having protein loss in the urine. Okay, you are having albumin loss in the urine. And remember, in case of your MCD, it is more of a selective proteinuria. Okay, what is the selective proteinuria? Because in case of your minimal change disease, it is predominantly a selective loss of albumin. Okay, So the other proteins are not lost in urine. It is predominantly a albumin loss in the urine. Okay. So about the protein, what you have got to do is that you have got to ensure a high normal protein intake. There is no need to restrict. You have got to give the patient, in fact, a high normal protein intake. Okay. And already you know that patient will be having hypercholesterolemia. So you must decrease the fat intake. Okay. You must decrease the fat intake. And now tell me that if there is a significant, say, edema, significant hypoalbuminemia, you sometimes will have to give albumin supplementation. You will sometimes have to give albumin supplementation. Okay. And what about diuretics? What about diuretics? The role of diuretics in case of your nephrotic syndrome? See, diuretics are given only if there is severe edema. Now, why do I say that? Because, see, when you have a bloated edematous child, there is always a tendency to give diuretics. You can give if there is severe edema, but always keep in mind, you have got to check the blood pressure also. Because in case of your nephrotic syndrome, the fluid is actually being lost to the extravascular compartment. So there is a chance of developing hypotension, because I have already told you there is hypovolemia. So if you give more diuretics, more hypovolemia, maybe more hemo concentration, complications like thrombosis can happen. So be very cautious. Okay, be very, very cautious when you decide to use diuretics in case of nephrotic syndrome. You can give, but again judiciously, okay, and only in the right patient. Okay, so in addition to steroids, fluid restriction, salt restriction, high normal protein intake, albumin supplementation, and diuretics as and only when required. Okay, so these are the general points that you have got to keep in mind for the management in case of nephrotic syndrome, minimal change disease. Now, see, patients with nephrotic syndrome, minimal change disease, okay, I told you this is a very much steroid responsive condition. Suppose this patient, okay, you have sent the patient on steroids. There is a good chance that the patient, suppose he was on 6 weeks steroids plus again tapered dose for 6 weeks, and he was better, he was in remission, okay. So everything was going fine, but see, in children, there is a good chance that there is a chance of a relapse. Okay, so what is the danger? There is always a chance of relapse in patients with minimal change disease, and the relapse commonly is associated with infections. So whenever the child develops some infections, there is a chance of relapse in case of your nephrotic syndrome, minimal change disease. Okay. So the relapse possibility is always there. So how will you treat a relapse? See, the relapse is again treated with steroids. Okay, even if you have a relapse, it is again treated with steroids. So it is always necessary that when you are treating a child with a nephrotic syndrome, you have got to tell the parents that, see, I'm going to start treatment with steroids. He is likely to show good response, but there is always a possibility that he may show relapses. So especially that occurs when your child may develop some infection. Okay. So in any infection, you have got to treat him early. Okay. So which means, infections can cause relapse. And how will you treat a relapse? Again, I told you it is with steroids. But instead of the 6+6 regimen, commonly in children, they go for the 2+4 regimen. Okay. So initially they will go for a 2 weeks of the full dose and subsequently over 4 weeks. Some would actually give it for 6 weeks also. Okay, the 1.5 mg per kg. So initial 2 weeks going for 2 mg per kg. Then 4 to 6 weeks you are going for 1.5 mg per kg. You are trying to decrease the dose and stop it. Okay, so that is how you will treat a case of relapse in case of nephrotic syndrome. So the next problem is, okay, suppose you have treated the patient. There are a few other entities. Some patients may develop frequent relapses. Okay, frequent relapses. So if some patient develops, frequent relapses in case of your minimal change disease, Then you will have to go for agents like your cyclophosphamide. Okay, so that is again given for frequent relapses. Sometimes you can go for cyclosporin also. Cyclosporin or tacrolimus also. Generally you will go for cyclophosphamide for frequent relapses. Okay, so relapses are treated with steroids. Frequent relapses you may go for cyclophosphamide. And what if the patient is having steroid dependence? The patient is having steroid dependence. Now what do I mean by steroid dependence? Steroid dependence means a patient is having two or more relapses when the patient is either on, say, an alternate day steroids, because see, when you give your steroid dose, initially you might give the initial period, you might give it say for the initial 6 weeks you might give it daily, but then subsequently you might bring it down to alternate days, or maybe you are tapering down. So suppose if the patient was on, say, alternate day steroids, and even despite the patient being on alternate day steroids, he develops 2 or more relapses, then you can say he is having steroid dependence. You can also say that he is steroid dependent if he develops 2 or more relapses, okay, within 2 weeks of stopping steroids. So he was being treated for a relapse and he was given steroids, and after another 2 weeks, okay, of stopping steroids, within 2 weeks of stopping steroids, he again developed a relapse, and if 2 or more relapses occur, then also you can say this is a steroid dependent condition. Okay, steroid dependent condition. And in case of steroid dependence, you can go for your calcineurin inhibitors. Okay, in case of calcineurin inhibitors, you can go for, okay, your steroid dependent condition. Very clear? Okay. So next is another condition, that is your steroid resistance. Steroid resistance. So what do I mean by steroid resistance? Steroid resistance means, you have put the patient on steroids, and even after 4 weeks, now remember, for this, for children and adults, the definition is different. For children, even after the patient being on 4 weeks of steroids, he is not able to achieve remission. So in spite of being on steroids for 4 weeks, not able to achieve remission, that is what you call steroid resistance. Okay, and for adults, instead of 4 weeks, it is 4 months. Okay, so in the patient is on 4 months of steroids, and even then he is not able to achieve remission. That is called steroid resistance. Okay, and steroid resistance, again you can go for calcineurin inhibitors. You can go for calcineurin inhibitors for steroid resistance. Okay, steroid resistance also you can go for calcineurin inhibitors. You are clear? So I will just show you a flow chart. Okay, this is for the treatment of minimal change disease in case of children. So don't worry, this is just a complicated flow chart. Okay, so but the general outline and the treatment we have already discussed how it is done. I just want to tell you, you see here certain points. One is I already told you, if the patient is having a frequent relapses, okay, he can be put on either cyclophosphamide or cyclosporin tacrolimus. If he is steroid dependent, okay, you can go for cyclosporin or tacrolimus. Okay, steroid dependent cyclosporin or tacrolimus. And you see here, if the patient is steroid resistant or non-responder, in that condition also you can go for cyclosporin tacrolimus. Okay, these points you keep in mind. The rest of the thing you need not actually by heart. But one more point just to add, see, if the patient is having frequent relapses or maybe a steroid dependency and not responding to maybe your cyclophosphamide, nothing, then you can go for rituximab. Okay, So always keep in mind the utility of a rituximab also, okay, in case of your steroid dependency and patients with frequent relapses. Okay, so this is how you manage children with minimal change disease. Why I am specifically saying children is because it is more common in case of children. So we have learned regarding this disorder, minimal change disease. Now let me tell you one important point also, because see, in case of pediatrics textbooks, there is some disparity in the management of your steroid dependency. Okay, so here cyclosporin tacrolimus, I have seen some pediatric textbooks going for cyclophosphamide. Okay, so that actually varies. It is less likely you will be asked such controversial questions with both being in the options, but I hope you have got the general overview of the management. I hope you have understood. Remember, this is the most common cause of nephrotic syndrome in case of children. It's a very important disorder, nil lesion, okay, or you can call it lipoid nephrosis. How does it clinically present? What are the complications? What about the investigations? What about the biopsy? What about the treatment? And also terminologies like say a relapse, okay, frequent relapse, and what is a remission, okay, and I'm sure that you would have learned the same terminologies in pediatrics also. And regarding the treatment of steroid dependency and steroid resistance, everything should be very clear. Okay, so I hope everything is clear for you. All right.